Hello, I am Bizrah, consultant ENT facial plastic surgeon. I published my textbook on rhinoplasty, facial plastic surgery in 2002. The book has more than 500 pages and 1,000 illustrations. The textbook was forwarded by the presidents of the American and European Academies of Facial Plastic Surgery and was distributed worldwide. I hope you find these videos are very interesting. It's designed mainly for surgeons, plastic surgeons and ENT and facial plastic surgeons. It's professional and educational. It presents my approach, my school, the Bizrah School of Rhinoplasty. You are most welcome and I hope you find it very interesting. This is an interesting case of deviated, severely cooked nose to the right side. As you see, the patient has got severe deviation to the right side, asymmetry. The deviation is more obvious there, you see there, and the tip asymmetry, and also she has got deviated nasal septum with right caudal dislocation. And this is the side view. So we are going to consider now septo-rhinoplasty under local anesthesia with sedation. So please watch our procedure now. Welcome. We are going to start now the septo-rhinoplasty. We'll start with the septoplasty as the patient has got right caudal dislocation there. It's quite obvious. So we start our incision along the caudal septum, just 1 or 2 millimeters behind, and we need to look for the right plane. The operation under local with sedation. Suction. I think we are now on the right plane. So the section is running. We are elevating the left perichondrial flap, as you see there. This is the cartilage, the white. See the white inside? Okay, the cartilage. So means the left perichondrial flap is elevated fully. And now we'll go for about 1 centimeter behind, or even more, and we try to elevate you need to get to the right plane first. Now we are on the right plane. Still start elevating the right perichondrial flap. When you are on the right plane, everything goes quickly and smoothly with no much bleeding. And you see now the cartilage in the middle. What is the cartilage? The cartilage in the middle now. Okay. Bandage jug straight away. With bandage jug we get the piece of cartilage out, because we will need cartilage for tip graft, for columnar strut, for spreader graft on the left side. So we need a good piece of cartilage with preservation of the dorsum lateralus. Okay, nice. To correct now the caudal dislocation, just underneath the foot of, see now, being corrected now, so you see the flap is returned back to normal position very nicely, and the caudal dislocation is corrected straight away, as you see now. So we finish the septoplasty now with the correction of the right caudal dislocation. You see the flap now very nicely returned back inside the midsection to a normal position without caudal dislocation. Okay. We start now our rhinoplasty. Transcartilage incision at level of the mid-kefir cusp and towards the midline. As we said many times before, always try to work in the midline. There is no need to go lateral. So mid-kefir cusp and towards the midline, try to preserve the lateral cusp, and then do some undermining. Okay. And now the tip is quite wide, so I do defining the tip. So we're going to trim the curvature of the upper lateral cartilage, because the supraolar fullness is combination of two factors: the curvature of the upper lateral cartilage and the lateral crust. I'm getting the mucosa away, as you see, and then gently trimming the curvature only of the upper lateral cartilage, only the curvature. So you see we left section. There's the upper lateral cartilage in place there. Okay. Again here, get a bit only because this is a deviated part, so we don't want to remove much cartilage. We want to preserve cartilage as much as we can. Okay, now we start our tibplasty. So this is the tip defining point, the junction between intermediate and lateral crust, and we go obliquely. As you see, we preserve the rim cartilage. Again, this is the tip defining point, and we go obliquely. And we preserve the rim cartilage. The patient has got tiny small cartilage, you have to be careful. Yeah, the patient has got very tiny small cartilage, very tiny intermediate crust. So we're getting the two intermediate crust to one side now, and then we'll make a bucket. In between the two medial crura, just above the nasal spine. The operation is under local with sedation, and the patient will direct in the procedure nicely. This is our graft now. I'm going to reshape. I need a tibia graft. That's the tibia graft. I need also the columellar strut and a spreader graft. This is a spreader graft. So we get the columellar strut first and insert in between the two medial crura. We social these three structures together, sorry, again. So we are creating a strong structure in the midline of two medial intermediate crura to the columellar strut in order to stretch the columella and to achieve more tip projection. So we're just removing this extra tissue there and this sharp edge here, and then we make another bucket now at the two caudal ends of the medial crura. Okay, and we put our tibia graft. So we are creating very strong structure in the midline to support the tip and to achieve tip elevation, tip projection, tip definition, tip refinement, and more tip rotation. Most patients like to have a very nicely projected tip with more definition and refinement of the tip. You see, under local with sedation, there is no much bleeding. Getting rid of any sharp edges in order to avoid demarcation. And then putting back the structure to the midline. You see now, we achieved more tip narrowing. You see very nice tip projection, very nice tip, nice symmetry, and nice tip definition. You see the tip, more tip definition now. Of course, the nose is still deviated, so we need to do the spreader graft here and the osteotomies, and then again we look at the tip and revise it. It needs more refinement. So now I would consider the spreader graft on the left side before doing the osteotomy, because I don't want the bleeding to make my life difficult. You see, so we go to the lateral cross. You see the upper lateral cartilage. You see the upper lateral cartilage very clear there, and we get a knife and we make an incision between the mucosa and the cartilage, because we want to go into a bucket. You see a bucket just under the cartilage, book section. You see under the cartilage and above the mucosa of the nose. Just lateral to the junction between the upper lateral cartilage and the dorsum septum. So now I've got nice pockets there. All my knife is in. You see now I'm going up and down, and my knife is in. See, between the mucosa and the cartilage, and then get the spreader graft. The spreader graft, and I will just push it now. Hopefully it will go quickly through this pocket. You see now? It's very nice. Just went to quickly, securely and safely into such pockets there. And this will give me more fullness now here, more fullness outside, and give me more symmetry between the two sides. Okay, because the patient nose is severely deviated to the right side, so we put the spreader graft on the left, and we just make a suture. Fix it, make sure it doesn't go out. Well, this is the easiest and the quickest way for spreader graft. And it's more safe, more secure. The graft will go straight to the right pocket. And if you need to do it on both sides, you can do the same on the other side. So now, having done so, we'll start doing our osteotomy, because the nose is deviated considerably and markedly to the right side, so we need to do mid-lateral first here. Mid-lateral. Don't go through the bone, we're going through only the bone and periosteum, but don't go through the endosteum. Keep the inside membrane intact. To avoid collapse of the bone. So it's like pressing on the egg. Here we don't need to do mid-lateral because this bone is short, the other bone is the longer one. See? I'm not getting through the whole compartment of the bone. It's like exactly pressing on the eggs. Okay, almost we have done. Okay, you see the patient tolerating the procedure very nicely. And now trying to mobilize. See, you heard maybe heard the tick. You see now the nose is absolutely straight. Look, now the nose is absolutely very straight. It was ghostly deviated to the right, now it's almost very straight and symmetrical. With the eyes closed to reduce the edema, and with the effect of the spider graft there, with the effect of the spider graft which we used here, the spider graft, you see, very nice, giving us more symmetry between two sides. If you don't use a spider graft, you will find this side going on inside, and sometimes give you misleading because you already have done your injection. You think it's fine if you don't use spider graft, but it's mandatory to use a spider graft because after a few months this will go inside from our experience, and then you have to do it again. Okay, it's very nice now, very nice and straight. We'll look at the lateral crust now, see if we need to do any more refinement. How many minutes here? You see this lateral crust is kept intact, no marginal incision, no exposure, no delivery, and we'll not touch it. So we leave it, looks fine. So you see, we did not really we did very little excision. So it's a technique based on incisions more than excisions. You are preserving the structure. The lateral crust is left there intact to support the alar sidewall. Lateral crust on the other side. Again, it looks quite nice. You just get rid of this sharp edge here. Okay. We get this off this sharp edge. You see, nice, very nice lateral crust in place, and you see all the cuts are coming together. So this will heal within few days, mucosa to mucosa, as you see there. And there, if you look there, you see again the mucosa to mucosa. See. So how many minutes? So actually we are less than 20 minutes. This is miracle really. We have done full septorhinoplasty. We did septoplasty, correction of caudal dislocation as you have seen there. And we did the tibplasty and the osteotomy and the right spider graft. Let me just give me straight needle.
30.
Yeah. And all been done as you see under local with sedation. So we get our nasal back out, no need now.
Back out completely.
And you see now all the tissue are coming together here nicely for the caudal dislocation being corrected. We just get what first suture and make it up. You see now, very nice there, very nice inside. Okay. Again. Okay. One more suture to secure. So that's enough. Please look inside here, and you see the intact clean mucosa, flaps. And then on the other side, look at the intact clean flaps. Very nice clean surgery. Less than 25 minutes. We have done full septorhinoplasty. Dry go. So I remind you with the you need to stay. Remind you with the situation now. before the severely crooked nose to the left, to the right side. You see the asymmetry and the deviation, marked deviation, the tip asymmetry and the coda dislocation, and the nasal profile. And look now here. You see now a very straight nose, very straight nose, very nice tip elevation, tip projection, tip definition, tip refinement, nail symmetry, and very straight dorsum. So we have done septoplasty, correction of right coda dislocation. We did tipblasty, we did left splitter graft, and osteotomy. As you see, it's very big change, very big difference, very nice profile again. So operation about less than 20 minutes. Full septorhinoplasty, septoplasty, correction of right coda dislocation, tipblasty, osteotomies, and left splitter graft. This is Bizrah consultant from BMC. Thank you very much.